Assalamualaikum warahmatullahi wabarakatuh. Good morning, the Honorable Director of Poltekkes Kemenkes Tanjungkarang, Mrs. Dewi Purwaningsih, Bachelor of Midwifery, Master of Public Health or Representative. The Honorable Senior Lecturer of Management and Science University, Malaysia, Madam Rahimah N. Muhammad. The Honorable Senior Lecturer of Management and Science University of Malaysia, Madam Sri Wahyuni Azhar. The Honorable Head of the Department, all lecturer and staff of the Department of Nursing at Midwifery, Poltekkes Kemenkes Tanjungkarang, and also the audience. First, let's give praise and thanksgiving for the presence of Allah Subhanahu wa Ta'ala. Because of His blessings and grace, we can attend and participate in this special event without any obstacle. It is great pleasure to welcome all of you to the International Expert Lecturer 2024, hosted by Poltekkes Kemenkes Tanjungkarang. Allow me to introduce myself. My name is Taskia Fazairawan, and I'm honored to serve as Master of Ceremony for today's event. This lecture is a wonderful opportunity for us to learn from experts and gain valuable insights. And we hope this event will inspire you and expand your knowledge. Ladies and gentlemen, to officially begin, may I kindly invite everyone to singing Indonesia Raya and followed by the March of Poltekkes Kemenkes Tanjungkarang.
Ayo, udah mulai tuh, Indonesia Raya.
Bangsa yang Mengabdi demi tugas mulia, Poltekkes Kemenkes di Indonesia, bekerja profesional mendunia, semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti di Dharma sebagai peruan kami, membangun hidup pertiwi tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat.
Thank you, everyone. Next, let us hear the opening remarks from the head of Center for Educational Development, Poltekkes Kemenkes Tanjungkarang, Mr. Gustav Amitiria, Bachelor of Nursing and Master of Public Health. For Mr. Gustav, the time is yours.
Gimana saya ini? Tes, suara saya terdengar?
Benar, Pak.
Terdengar ya. Assalamualaikum warahmatullahi wabarakatuh. Puji dan syukur kehadirat Allah Subhanahu wa Ta'ala, di mana pada pagi ini alhamdulillah kita bisa bertemu di dalam Zoom meeting pada kesempatan hari ini. Pertama-tama puji dan syukur kita ucapkan selalu kepada Allah Subhanahu wa Ta'ala, di mana kita diberi kesehatan dan nikmat kesempatan. Bapak Ibu yang saya hormati, pertama-tama saya sampaikan permohonan maaf dari Direktur dan unsur pimpinan pada kesempatan hari ini masih ada kegiatan yang lain sehingga memberikan mandat kepada saya untuk membuka kegiatan kita pada hari ini. Mudah-mudahan tidak mengurangi arti daripada pertemuan kita hari ini. Honorable ladies and gentlemen, attendees and happy student, and thank you for Vice Chancellor Madam Rohimah and Muhammad and Madam Sri Wahyuni, Senior Lecturer MSU Malaysia, in the 2024 International Expert Lecture activity in the Nursing and Midwifery Department of Poltekkes Kemenkes Tanjungkarang. Hopefully this activity will benefit us all in the development science. Pada kesempatan hari ini, Madam Rohimah and Muhammad, Bapak Ibu akan memberikan materi terkait dengan comprehensive midwifery service to reduce maternal mortality. Dan Madam Sri Wahyuni akan membawakan materi tentang nursing care for home care service for stroke patient. Ladies and gentlemen and attendees whom I respect, the scientific activity is carried out in order to follow up in the MU. This has been made together in international cooperation in the three Dharma activities for her education. Hopefully the material provide for both nurse and midwifery can provide enrichment for all us. Hopefully this activity can take place well. We also thank MSU for the willingness to provide speaker in this activity. Hopefully the cooperation can continue and be improved in the future. Thank you. Bapak Ibu, demikian mungkin sambutannya. Kami mengucapkan terima kasih yang sebesar-besarnya atas kehadiran kita semua. Mari kita dengarkan. Mudah-mudahan kegiatan ini memberikan manfaat bagi kita semua. Demikian saya akhiri, wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Gustav, for the warm and inspiring remarks. Before we continue, we would like to capture this special moment for all participants who does joining us via Zoom. Please turn on your cameras for the documentation session. For all participants, please turn on your cameras for the documentation session. Okay, I will guide the documentation from the first slide, so make sure all of you have turned on your cameras. Okay, the documentation will begin in slide 1. 1, 2, 3, smile. Okay, slide 2. 1, 2, 3, smile. Slide 3. 1, 2, 3, smile. Slide 4. 1, 2, 3, smile. Okay. Thank you everyone for your cooperation. And the next agenda, we are now ready to move on to the main session of today's event. To guide us through this session, I'm pleased to introduce our moderator for nursing session is Mr. Wimba Widagdo Dinutanayo, Master of Science. And for the midwifery session is Mrs. Rovana Agnia, Bachelor of Physiotherapy and Master of Public Health, who will lead the presentation and discussion. For Mr. Wimba, the time is yours.
Yeah. Hi, Taskia. The first moderator is Bu Rovana. Bu Rovana first.
Oh,
Yeah,
I'm
then
sorry.
me.
Okay, I'm sorry. Okay, for the midwifery session, is Mrs. Rovana Agnia, Bachelor of Physiotherapy and Master of Public Health, will lead the presentation and discussion. For Mrs. Rovana, the time is yours.
Thank you, Ms. Taskia Faza Irwani, for letting me into this Zoom session. And before we start our expert lecture, I'd like to introduce briefly about our international speakers from MSU. Can I share the screen? Wait. Okay. Our speakers today is Madam Rohimah and Muhammad, Senior Lecturer from MSU Malaysia, and will lead us, will give a session, a lecturer about comprehensive midwifery service to reduce maternal mortality. Mrs. Rahimah is dedicated in nursing and midwifery professional with 22 years of combined experience in teaching and clinical practice. Since 2010, she has been a lecturer at Management and Science University, MSU, Malaysia, where she has been instrumental in shaping the next generation of of nurses and midwives through her expertise in critical care nursing and her passion for maternal and neonatal health. She is currently pursuing a Master of Nursing and hold a bachelor's degree in nursing with a specialization in critical care. Her work emphasized the integration of clinical excellence, patient-centered care, and evidence-based practice in teaching. Ms. Rahima has also contributed to international research collaboration and showcasing her commitment to advancing healthcare education and improving patient outcomes. Before we move on into this section, I'd like to invite Mrs. Rahima to join us today. Oh, I'm sorry, my camera is off. Yeah. Ms. Rahima,
Yeah, thank
good
you.
morning.
Yeah, morning. Can you hear my voice?
Yeah, your voice is sound incredibly clear.
Okay.
Okay. Are you ready to give your invaluable information today?
Yeah, it's
Yeah.
enough.
Okay. Without further ado, let's call and let's invite Mrs. Rahima with applause. Yay.
Okay, thank you, Rofana.
Time is yours, Miss.
Okay, do you see my slides full?
Yes, it is clearly full.
All right. So thank you, Rofana. So first, before I start, Assalamualaikum everyone and good morning.
Good morning.
All right. Okay, first of all, I would like to say thank you to the line of the management of the Paul Tekers Commences Tanjungkarang for inviting me to deliver this sharing session on the comprehensive midwifery service to reduce maternal mortality. It's a good topic basically for us, especially for the midwife, because this is we align whatever that we do, what actually the intervention that we do to the patient itself. So it must be goal driven. So our goal driven here, but today is a focus to the maternal mortality. Basically, our roles as midwife, we are cattle to of the life, which is mother and also the infant itself. But for today, for our topic, we are focusing on the maternal mortality. So maternal mortality actually is the global issue, the main concerns. If you search on the WHO and also UNICEF, they are talk a lot about the maternal mortality. Why we are so concerned about the maternal mortality? Because maternal mortality is one of the reason that show on the what actually the country is look like. It reflect the growth, the effectiveness, the efficiency of the country itself to control their population. It's through the maternity. Okay, so today we go to the this topic. So for today's sharing sessions, so we hope that towards the end, we will conclude or understand these three outcomes. So the first, we hope that we can understand the relationship between what will be the midwifery service and what is the relationship in reducing the rate of the maternal mortality. That's number one we want to achieve for today's session. The second one, we want to know the overview of the global and also the regional maternal mortality statistic that we have. So the global and also regional mortality rates that I have here, I try to share is about the worldwide statistic and also from Malaysia perspective and also from the Indonesia perspective. I hope so that the statistic that I've shared after this might be the current ones for both of the country. And the last one, we want to discuss what will be the comprehensive role of the midwifery in reducing the maternal deaths. So in reducing the maternal deaths is not the one show man's activity. It's not only relies on the midwife only, but it actually is a collaborative between the few interprofessional roles. So to improve the maternal mortality. So we go to the introductions of the maternal mortality. So before we go further about the strategic plan on how to reducing, so we need to know actually what actually is the means of the maternal mortality. So maternal mortality is defined by WHO is refer to the cases of the death due to the complications of the mother itself during the pregnancy periods or during the childbirth. So this one is exclude the accidental or incidental causes. So accidental means that the trauma, the incidental might be due to the poison and so on. So that's what is excluded. So what we are focused here is only the cases of the maternal deaths during the pregnancy, throughout the 6 months of the period, during the childbirth. Childbirth is during the intrapartum, and also we include the postpartum period. So we know that postpartum period or puerperium period is inclusive of the 42 days. So 42 days is referred to the 6 weeks approximately. So from the beginning of the pregnancy until wrap up to the puerperium, we estimate about 6 months plus, or maybe it's 11 months of the comprehensive monitoring should be done by the midwifery. So this comprehensive monitoring is the key main factor. Effectiveness in monitoring can lead to the reducing of the MMR rate. So how we calculate, how we know that the maternal mortality rate is reducing or not, is referring to the calculation of the maternal mortality ratio. So how we calculate MMR is refer to the number of the maternal deaths during the given time period per 100,000 live births during the same period. So the same period here is referring to what the government or the country referring. For example, if we calculate is in 1 year, so it must be start from the 1st January until to ends of the December, 31st December. So this will be the time period. So from this time period, so we need to calculate how many the maternal deaths occur and how many the live births is we have. So that will be the MMR. So we do have, every country have calculate the MMR every year, and we translate to the pattern for every year because we want to check, is it whatever that we implement to our mother or to our service, is it reflect, is it effective or not to the maternal well-being? So it's through the MMR. So the bottom part, I put in the maternal dia punya summary or the formula, which is the maternal mortality ratio, number of maternal deaths over number of live births, and then we need to time with the 100,000, and then you get the MMR. So why we are so concerned about the maternal deaths or maternal mortality? So maternal mortality remain the major global issue, which is also highlighted by the WHO and also the UN. I'm sure that everyone know that United Nations already come up with the SDG Sustainable Development Goals. So one of it is agenda in the SDG is reflect to the mortality rate. In the SDG already stated that we try our best in 2030, our objective to reduce the global mortality rate MMR to 70 cases per 100,000 live of births. So it's huge, different from nowadays of the statistic, but it can be done, it can be achieved. So how we can achieve this objective is through the comprehensive service that we propose or we deliver to the mother. So what is it? So we discuss after this. So what actually the coverage or area that must be focused. So next we go to the statistic, global statistic of the maternal mortality statistic. So this is from the WHO and also the UNICEF. So they come up with the statistic on the 2020. So they come up with there is a 287,000 maternal deaths reported in 2020. So this estimate is around 800 cases of maternal death per day. And then when we break up, it could be 1 cases of maternal death in every 2 minutes. Can you imagine? Every 2 minutes, one mother is die because of this. There's a many reasons why the mother is dying. And then when we look at the patterns, okay, we look at the global patterns, so we can see the reductions of the number. Compared to the 2000, we have the 339 death cases per 100,000. But in the 2020, we can see that the case of MMR is reducing to reach 223 deaths. So it's good. It's reflect the good activity that we implement to the healthcare. So when we look in depth, what actually the causes of the maternal death? So we come up with the major contributions. Contributor is come from the hemorrhage, it's come from the infection the patient has, and also we have the hypertensive. So we know that this all is the variable that can influence the maternal health. Hemorrhage can be happens during the antepartum, it can be happen during the delivery process, the interpartum, and also can be happen during the postpartum. That's why I said just now, so midwife must monitor the total up is about 11 months of the mother to ensure that we try to prevent for the maternal mortality. Next, we have the infection, hypertensive. Hypertensive can be is primary disease or might be is the secondary disease. Means that mother pregnant with normal and then in between they have the hypertensive. So it also can contribute to the high rate of the maternal mortality. So from the data that we have from the WHO, we try to get to in depth what actually causes, which area actually that represent the high rate of the MMR. So we identify there is a 94% of these death cases is occur in the low resource setting. So when we talk about the low resource setting means that it's about the facility available for the mother to reach. It's about how about the mother or the community can reach to the nearest hospital, the nearest clinic to get the treatment. So that is a low resources. So this might be is reflect or influenced by the geographical maps of the where they are living. So most of it due to they are living at the rural area. They are lacking of the transportation, is not proper. They are timing consuming to reach to the facility. So might be this will be contribute to the high rate of the maternal mortality at that area. So in the WHO report also, they are trying to get in depth which area in the world contribute to the most of the maternal mortality. So we can see there is a disparity by the regions. Okay, after that we see the maps. Okay, disparity of the region here we can see there is a lot of the cases of the maternal deaths. It's occur at the sub-Sahara African, which is contribute to the 60% of the maternal death globally. So it's African basically. And then some of it, okay, we have the Southern Asia and also sub-Sahara Africa, which is combined contributed to the 87% of the global maternal deaths. So now we are thinking about what about Malaysia? How about the Indonesia? Okay, so this is the fact from the WHO and UNICEF. So this is our concern. Why? What happens there? So that is the question that need to answer and need to be try to solve in future. So look at this trend. So this trend is worldwide trend of the maternal mortality from the 2000 to 2020. So look at the color. Okay, dah nampak dah mana Indonesia? Okay, I'm also looking at Malaysia. Where is Malaysia? Okay, so look at the color. The dark blue color represent the very low maternal mortality rate. Okay, in the trend. So it's good. Means that very low is below than hundreds. So that will be our target. Next, the light blue color is represent the low case of the maternal mortality, which is between 100 to 299. But our concern here is the yellow color until to the red color. The yellow color is classified as a high area with the maternal deaths is between 300 until 499, followed by the orange color, very high, with the 500 to 999 cases per 100 cases, 100 million case, 1,000 cases, and the red color is extremely high, which is the dead cases is more than 1,000 occur per year. So that is, we are trying to identify why. When you look at the tabulation of the color, so the color is specific at that area in the African, and that is the sub-African, sub-Sahara. So we know that sub-Sahara is the too huge, unable to underserve of the too rich for the facilities. So that will be the reason behind why the mortality cases is high at that particular area. We look at the Malaysia and also Indonesia. So we under low and also very low trends. So which is good, means that whatever they implement, Ministry of Health strategy is good in the maintaining the or reducing the maternal mortality. But we still need to look, is there any gaps? Because they still have the maternal deaths, but what actually the gaps that occur at our country? So next we go to the Malaysia. This maternal mortality rate in Malaysia, I get from the 2014 until 2023. So we can see there is a reduction. So we look at the 2022 compared to 2023, there is a slightly reduced from the 26 to 25.7. It's only 0.3, but still it's significant reductions. But this pattern, even there is a reducing, but you can see the whole pattern from 2014 until 2023, the pattern is fluctuations. Some is going up, some years is going down, some up very huge at the 2021, and then it's become low again. So we need to look at every year. What happened actually at that particular area that year that can cause the maternal rate is very high. You can see at the 2021, what happens that time? 2021 is the second wave of the COVID-19. So what happened during the COVID-19? So we have the movement control order, which is everybody must be stay at home. So that might be the contributor factor why the mother unable to reach for the facility because they are afraid of the spreading or infected by the COVID-19 and some more. So that might be the reason behind of the 2021. So let's look for the Indonesia. Okay, so these patterns of the Indonesia, but only I get from the 1990 until 2020. Okay, in Indonesia, because of the geographical of the Indonesia, you have the large area country, and also your total population also is very high. You have 270 million population. Is very packed. Okay, so that's why we can see the variety patterns of the maternal deaths in the Indonesia. So we can see here this divide by the regions. Okay, in Indonesia, right? The MMR national MMR of the Indonesia, seeing that there is a decline from the 450 to 249 cases between the 1990 to the 2020. So this is a great difference in the MMR exit across the country with we can see at the lowest Java, Bali, okay, and the highest you can see at the Sulawesi, which is a triple, twice from the beginning, and also at the Eastern Indonesia. Okay, so that's high at particular area. So between the 1990 until 2022, the proportion of that is due to the hemorrhage and also due to the sepsis. We see there is a decreasing in the pattern. Okay, next, we can see there is a patterns is not particular. What I can say is not a particular remaining at the same state. It's still fluctuating, okay, from the 1915, and then it increased. The pink color is Eastern region, and at the Sumatra, we can see the reduction is good from the 784 reduced to until 142. So this variable means that they still have a gap in the Indonesia. So we need to tackle. Okay. Okay. So the gap that we said just now has been described by the Thaddeus and also May. They come up with the 3 delay model. They identify why the maternal death is occur because of these 3 problems. So first, the mother is delay in deciding to seek appropriate medical help for in the case of the emergency. So this delay can be happens due to the conflict of the mother itself among the family, or might be this is happened at the health clinic at the rural area. Either they want to decide to refer these cases to district hospital, or maybe they can solve their problem at the rural clinic. So that is the delay in deciding the seeking for medical help. Number 2 reason is delay in reaching the appropriate obstetric facilities. So this happen might be from the family itself, from the house, they go to the hospital itself, or might be is happen from the rural clinic. We refer or bring the patients to the secondary hospital. Might be because of the way, the time, the traffic, the transportation available that can cause the delay in the reaching of the obstetric facilities. And the third model on the delay is occur because of the delay in receiving adequate care once the facility is reached. So it means that patient already reached to the hospital, but at the hospital itself, we are delayed in giving the treatments for the patient. So why this happen? Might be because of the pack of the patient, because of the we are shortage of the expert staff to deal with the cases. We have delay, or maybe we are shortage on the consultant to consult about the cases, complicated cases. So this will be contributing factor why the maternal mortality rate is increasing. So now we go to the what will be the cause of the maternal mortality. So this also from the WHO, they summarize that this will be the key factor or cause of the maternal mortality. So nearly all, or it's about the 99% of the death is due to the abortions. Okay, this is due to the unsafe abortion. So unsafe abortion means that the mother do the abortions not in the facilities, medical facilities. Might be they do by their own or something. So this include the deaths of the obstructed labor and also due to the severe anemia of the patient. Next is about the indirect cost. Indirect cost contribute to the 28% of the maternal mortality. So indirect cost here is referring to the medical causes such as pre-existing conditions aggregate by the pregnancy. For example, just now we said about the patient is having, might be is have preeclampsia and so on during the pregnancy, or GDM, that's also contribute to the maternal mortality. The second contributions factor to maternity, that is the hemorrhage. I said just now, is hemorrhage can be happen throughout the pregnancy. It start from the pregnancy, during the antenatal, intranatal, and also the postnatal. So it's contribute to the 27%. So the rest also is contribute to the mortality rate, which is followed by the hypertensions. We have the other directed sepsis and so on. So that's will be the main concern about the cause of the. So all these cause basically is preventable. Okay, preventable and manageable. So with the comprehensive service that we supply by the midwife and also healthcare provider, so all they can manage and also can prevent, and also indirectly we can reduce or avoid the maternal mortality. So what happens to my slide here?
Looks like one of the participants is activating the annotate.
Okay, never mind.
Bunga is someone here named Bunga. Could you please turn off your annotate? Okay.
Okay.
Oh my God,
It
it's
transfer. Okay, never mind. We can continue. So next, after we know what will be the causes, we also need to understand what will be the risk factor that will increase the morbidity of the mortality of the maternal. So there is a lot of the additional factor that contribute to the maternal mortality. For example, we nowadays are facing with the younger mother. Okay, which age of the now is this trend start from the 13 already pregnant. So we know that this age really influence the maternal well-being. If the maternal age is too young, okay, 13, 14 years old, they are very high risk to get the preeclampsia. So we know that preeclampsia is the major contributor to the maternal mortality. Besides, if the mother is older, so in Malaysia, we identify that 35 years old is considered is risk for the pregnancy, but still we have the mother more than 35 pregnant. When we take mother with the high risk, so we need to closely monitor the mother throughout the pregnancy, because they are prone to have the bleeding and so on during the delivery. Next is about the life changes. So nowadays we can see regardless male, female, they are more changing their lifestyle. So we can see there is a bean currents. Mother can be a former cigarette smoker. Nowadays they are taking the vape. So all this also will contribute to the maternal mortality. So how? Because of the nicotine that contained in the cigarette itself. Other than that, multiple pregnancy, complication during the pregnancy such as preeclampsia, diabetic mellitus also give the major impact on the well-being of the mother. So when is give change of the maternal well-being throughout the pregnancy, so it also will be risk for the mother to have the complication during the childbirth and indirectly cause the maternal death. Other than that, we have the certain features of during the labor. So some of it we have the VBAC, vaginal birth after the cesarean. So this need the specialist or expert to identify either the mother is suitable or not for the vaginal birth after the cesarean. So this must be evaluated based on the previous cesarean, the site of the incision, the nature, the thickness of the uterus, either is suitable or not for the vaginal delivery. If not suitable, we are encourage patients to do the second cesarean section. So this is to help to prevent for the complication, mother and also for the baby. And the first delivery mother also is high risk to get the complication. Even the mother is delivered via vaginal, they are high tendency to get the trauma of the perineum. So nowadays in Malaysia, for example, we are not encouraged to perform the episiotomy. So we know that episiotomy is help mother to fasten the secondary process, second stage of the delivery. But in Malaysia, we don't want to make it as practice. So if indicate, for example, there is a poor effort of the mother, or maybe we can see there is a well-being of the baby itself, the fetal heart rate is reducing, maybe we need to help with the episiotomy. But originally now we are not practicing of the episiotomy if not indicate. Because we don't want to make it habit of first delivery vagina, so we must do the episiotomy. Not necessary. It's not necessary. But if the problem with the episiotomy, if you not do the episiotomy, so the trauma of the perineum become more worsened. You can get maybe the second stage, third tear, fourth tear, which is difficult. We want to correct or to manage, then lead to the bleeding. Other than that, also we have the factor that contribute to the maternal mortality. Also is depend on the racial, ethnic, and also socio-economic background. So this one is referred to the trend just now I share with you, which is referred to the Africans. Okay, because of the nature, maybe it's due to the culture that they believe. So when we know the gaps of the maternal mortality, so we need to address what will be the barrier for the midwifery service. So we identify there is a 3 barrier that need to be tackled. So first is about the culture perception. So culture perception is referring to the nature of the races itself. So some population, they want practice their belief, okay, because it's depend on their health belief. So some of it, they believe that they need to deliver at home because all the traditional family member all are delivered at home. Some of it, culture perception is because of they are lacking of the mother rights. I'm saying this because of there is a cases where patient is pre-eclampsia stage, the first baby, first delivery. So after labor, we advise patients, okay, they need to take the family planning because we're afraid that if immediately after this, they're pregnant, so the condition become more worsened because this only first child. How about the second child? So we are caring about the mother health actually. But what happened when we advise the mother? The mother said, I can't give any promise to you because I need to obey with my mother. My mother is the right to say so, what I'm going to do. So that actually the barrier that we face in the community. I'm sure that everywhere have this culture perception or barrier. The second barrier that we face in the midwifery field is about the policy and also regulatory change. So challenge here is referring to the policy maker. Policy maker is about the government and also our Ministry of Health. So how they handle, how they control their facilities, how they are preparing the manpower for treatments of the mother. So this is about the policy and regulatory challenge. And the last one is about the access in rural and also underserved areas. So this one is rural area, how to catch the area to ensure that the mother get the best access to the health facilities. So that will be the barrier that we need to sort out. Okay, now we go to the goal of the comprehensive midwifery service. So the goal is only 3, which is first, we want to, as possible, we detect, is there any complication that mother has during the pregnancy? So when we can catch early the complication during pregnancy, so we can monitor and manage throughout the pregnancy until to the preparing phase. So that's number 1. Number 2, we are promoting the safe childbirth practice. So promoting the safe childbirth practice is referring to what the delivery choice that made for the mother. So this delivery choice of the mother is depend also to the mother condition. Okay, so in the case of the, for example, uncontrolled diabetic, we have the hypertension patient is the preeclampsia. So if the condition is stable, manageable, we allow patient to deliver via vaginal, spontaneous delivery. But if the condition is not tolerate, is not controlled, we are suggesting advise mother for the cesarean section because of the well-being of the mother and also the infant. And the last one, the goal is about the promoting or support, psychological and also emotional support of the mother. So this is very important because we want to prepare the mother. Mother must know their conditions. When they know about their condition, they aware about the condition, they are comply with whatever the advice and also treatments that we plan for the mother. So that's why emotional and also psychological preparation is very crucial for the mother. So next we go to the what will be the components that include in the midwifery service. So just now I said about the midwifery is tackled from the first beginning until right up to the end up to the puerperium phase. So in the midwifery, so this will be the area that need to be covered. So first we have the antenatal care. Antenatal care, what we do is we do the early regular checkup and also we do the risk identification. The second phase is about the intrapartum. So antenatal care basically is happen at the clinic. So when we go to the labor process, so that will be the intrapartum. So during the intrapartum, so we must make sure that whoever that handle the delivery process, it must be skill-based. They know what to do. They know how to identify the complication or sign of is there any problems during the delivery. And also they are able to manage the complication if they detect. And also they must practice the safe delivery level. So this start from the first stage level until right up to the third stage of level. Next, midwifery service also must cover the postnatal care. So after delivery, basically mother will be posted to the postnatal ward for 1 day or maybe until up to the 3 days, depend on the condition. But midwifery, so we need to tackle postnatal care of the mother. We need to monitor the recovery. We need to check the bleedings, access the peg charting and everything of the patient. Include the family planning. Mother basically don't want to hear about the family planning because they say that anak ni anugerah, that's it, is rezeki. But the concern of the midwife, basically why we emphasize on the family planning, because the family planning is one of the method on how to ensure that the well-being of the mother body is fully recover from the delivery. So that's the main key point of the family planning. That's why we are very concerned. So we also concerned about family planning because first is about the recovery. The second one is about the spacing of the baby or child. So when the spacing of the child, so it's actually refer to the contribution, the fully care of the mother or family towards the baby itself. So can you imagine if you have mother with the delivery every year? So if delivery is every year, means that the gap between the first baby and the second baby, during 6 months, mother already pregnant for the second one. So how about the well-being of the mother? So during the check-in, you can see there is too pale, too anemic, mother is too tired, fatigued, cannot take care of the baby itself, and also cannot take care of the health also. So that's main concern why family planning is very important to the mother. After that, we also have a lot of the health education given to the mother. So this education is right up from the antenatal preparation, intrapartum, and also postpartum health education. So this education also is to prevent of unwanted pregnancy. Mother is not prepared for pregnant, but already pregnant because they don't know what actually resources, what actually method to do for the spacing. So that's comes our role as a midwife to take part. So next we go to what will be the strategy to reduce the maternal mortality. So first, just now I said is about the early detection of complication. So this is occur during the antenatal care. So antenatal care, so most of our midwife at the clinic, so we must expert on how to do the checkup, assessment of the mother. So during the booking, basically we advise mother to do the booking before 12 weeks of the gestation. So that is the period during the first trimester. So after the booking, so during the booking itself, we do the screening assessment for the mother. We take note from the previous pregnancy, is there any complication, is there any sign and everything. So after we complete the assessment or assessment of the mother, so we will tag mother with the color coding. Either it's white color, either it's the yellow color, green color or red color. So this color tagging we put at the mother maternal card. So it represents the severity of the mother condition. So wherever the mother go for the checkup, either after this they go to the hospital, then bring the card. So the person in charge at the hospital know. So this is high risk patient, need to be taken care. So that is the continuity of the care from the clinic to the secondary hospital. So the second one, after the secondary, after detection or assessment of the mother, so we follow the frequent follow-up, subsequent follow-up with the mother itself. So basically from the first trimester until right up to the 38 weeks of the gestation, so we give appointment on the monthly basis, means that 1 month, every 1 month, every 1 month. That is for normal pregnancy. If the mother is having the complication, for example, develop hypertension or patient already have the diabetic before the pregnancy, so the duration of the appointment will be shortened because we want to monitor the progress of the mother and also the progress of the baby itself. And then after the gestation is near to delivery, so the frequent appointment also will be shortened. We give the 2 weeks, every 1 week, and so on. And also concurrently during the antenatal checkup, we also include the health education towards the mother. So during the pregnancy, we give the information or educate mother about the diet during the antenatal. So mother might be feel this is useless and so on. But for us as a midwifery, we know that if the mother is malnutrition, what will be the complication that can be happen? Patient in severe anemic, for sure you need to get ready with a lot of the blood during the labor process. So this the important on continuously health education to the mother. So towards the 37th week of this gestation, so our health education also will be changed to the preparation for the delivery. So we advise what will be the sign or symptom of the delivery. If you have this sign, bleeding or break of the liquor, you need to immediately come to the hospital. But even we implement this, we remind the mother every time of the scene. Still, there is a mother that didn't practice. They keep relaxed at home and delay go to the hospital. There is one case. There is one case I managed previously, which is patient already in gestation 6 should be it doesn't issue because they already have the experience, the feel of the delivery process, sign of the delivery. So what happens? Patient is working, patient feel the contraction, but patient is ignorance the feel of the feeling of the labor process. So patient is only come to the hospital, patient is delivered in the car, not reaching to the hospital. So what happens during the delivery? So there is a cord round neck of the baby. Baby comes to the hospital with the moderate asphyxia. You can imagine how the emergency staff handling with these cases. So that will be the the conditions. That's why early detection and also high education is very important to the mother. So the second strategy on reducing maternal mortality is a referring system that we have. So in our healthcare, so we have the staggered, okay? We have the primary, we have the secondary, and also we need to have tertiary. For the maternal health, so the primary, secondary, and tertiary basically is referring to the system that we have. Primary basically is that the clinic itself. So during at the clinic, we do the checkup, we detect for is there any complication and so on. We do the follow-up. So anything might be complete, there is complication and so on. So the midwifery must refer the patient to the secondary. Secondary treatments basically is stated at the hospital. Basically, it's district hospital. So we send patient to or refer patient to the district hospital for better management and treatments. So some cases which is complicated, which cannot be managed at secondary hospital, must be referred to the tertiary hospital. Tertiary hospital is the hospital with all the consultant and specialists, especially the neonatology. So there is one cases previously I deal, which is patient is having the abdominal pregnancy. So abdominal pregnancy is the pregnancy, mother pregnancy, it's outside from the uterus. Okay, so the baby is mingled around the peritoneum. So mother didn't expect that they are pregnant because there is no sign of the pregnancy. Patient is having the irregular period also, so doesn't know that patient is having the pregnancy, baby. They realize until up to 27th week of the gestation, when they try to eat, they can't tolerate with the food. They keep vomit, eat, vomit, and then they come to the hospital. We do the scan. The doctor do the scan, check for the abdomens, for the gaster. Oh, there is no problem with your gaster because the doctor itself is not expert in the maternal obstetric. So that's only the medical doctor. So doctor just give the antacid and let patients go back to the home. Then the sign is not decreased. Patients come to seek for the second opinion at the other hospital. So when we do the screening, identify that there is a child, there's baby, but it's outside of the uterus. Immediately, the mother is admitted to the district hospital. When we do the discussions among the interprofessional, the doctor, expert, and also, we can't manage the cases because we are lacking of the facilities for the baby. We are lacking for the expert for the mother itself. So we refer to the tertiary hospital. In Malaysia, we refer to the HKL. So patient is sending to the HKL. So we make appointment and all the consultants throughout the Malaysia, they are gathered at the HKL to manage the cases. So basically, if the mother is having the abdominal pregnancy, we can see there's a 50-50 survival rate. So it means that either both is dying or maybe both can be survived. So we already explained to the mother, they need to take the long leave, minimum is 3 months, okay, to cater, to manage of the problem, maybe more than 3 months because of their conditions, because we don't know where actually location of the placenta is implanted. Okay, so what happens after that? So the delivery is success, surgery is success at the HKL, Hospital Kuala Lumpur, and both is survive. This survival is due to many reasons because we are prepared, we are communicate each other, we are discussing, and we prepare all the expert to manage the condition. And then both is survive. So that's a very important why referral system is crucial in the managing for maternal health. Next is about the interprofessional collaboration. Internal collaboration, just now I saying about the communication and also work together on how to manage the cases. So interprofessional is not only for the obstetric surgeon or specialist. It also involved with the neonatology, anesthesia, and also surgeon. After that, we have the obstetric emergency care. Is about the access and also transportation. So for this actually is related with the policy monitoring and data collection. So for the involved with the budgeting that provided by the government. So every year government will come up with a budget, how many billions for the healthcare. So government must invest with the healthcare facilities. Same with this, if the area is far from the hospital or far from the healthcare facilities, maybe government need to look into, you need to come up with build up a few more facilities that near to the community so that the intervention, the monitoring system can be aligned. About the transportation. Transportation is about us, we have the ambulance, but at healthcare center, we don't have much ambulance. So, but transportation here is referring to the, maybe we have, government need to invest on the proper pavement of the road for the community so that they are reaching the health facilities more faster compared they need to mingle around with the obstacle in between. So that will be the involvement with the government. Beside that, emergency cases also, we need to invest more on the manpower. So manpower here, we need to make sure that our midwifery, our doctors is expert and well known how to manage the cases. So how to ensure that? So we must send patient for the professional investment program. Okay, make sure that they are up to date, what will be the current practice, so that we can implement when dealing with the patient. And the last one strategy that we use to reduce the maternal mortality is about the educating the community. Community here is about we try to break the perception or cultural of the family members or the community. This is to ensure that they understand the condition, the crucial of the condition of the mother itself, and also they understand about the preparation of the mental health the mother, and they are prepared, ready for the delivery and take care for themselves. It's useless if we are doing all the checkup everything, but whatever that we try to implement to the mother is not synchronized with the compliance of the activity. So we must understand that, for example, mother with the anemic, so we advise, we give mother with the hematinic, we supply mother with hematinic. And then afterwards, the next appointment, we check why the HB level is still low, because mother is not compliant. So that is very important that education with the family member and the patient itself, they are parallel with our understanding. So when they understand, they obey with what treatments that we plan for the mother. So when the parallel of the intervention between the healthcare provider and also the mother itself, so we can see the result of the improvement of the condition of the mother, so that the maternal mortality rate can be reducing. So this will be the strategy that we implement. So if you look at the WHO, they are come up with many more, such as we have emphasized on the sexual and also the delivery care. So that's some of it. They catalog the malnutrition cases and so on. So that's some of it, but this one is just deliberate for the maternal mortality. So as conclusions, as overall, so the comprehensive midwifery services are essential to reduce the maternal mortality. They are provide the high quality and cost-effective care, particularly when scaled for the unserved region. Okay, we have the community nurse. In Malaysia, we have the Jurok Masyarakat. For those who are unable to come to the hospital, to the nearest clinic, we also provide the home visit as service, where our nurses or midwife go to their house and do the checkup and screening during the antenatal and during the postpartum. So this also is how we reach to And also, it's crucial to expand the access of the skilled midwife. So the government must invest on this. Maybe we need to train more student midwife, and also distribute to all over the region to cater the community. So in Malaysia, previously I asked about the Jerawat Masyarakat, we have the public nurse. How many patient community that you cover? So one midwife, one public nurse covered about 6,000 people. I think it's quite a huge number to cater. Maybe in future we need to enhance this also and build up and increase the number of the staff so that the inclusive exercise or inclusive intervention can be met throughout the region. I think that's all for my lecture, my sharing sessions today. So this will be the reference that I use for my presentation. Okay, thank you.
Thank you, Madam Rahima, for your insightful presentation and information. So, dear all participants, we will now proceed to the Q&A session. If you have any questions, please raise your hand and I will call you on in turn. Kindly introduce yourself briefly before asking the question. And for students who are joining us virtually through the YouTube, please type your question in the chat or send to the messenger, and I will read aloud for Madam Rahima to address. Okay. Is someone already raised a hand? Not yet. Okay. Okay, it is inspiring that Malaysia has very low maternal mortality, while here in Indonesia, we still has a various maternal death. As we can see in your picture, in your slide before, we still have a light blue color comparing to Malaysia that has a darker shade of blue. A geographic factors might be contributed because we are here has a lot of islands and yeah, somehow it make our transportation is limited and so on. Do you have any suggestion to our students, because they will be the health workers in the future, to make a belonging sense that to build their responsibility later as a health worker?
Yeah. Okay. So for the students, what my advice, okay, regardless what the reason that you join the programs, some of the students I asked, they are not interested at all in nursing, but they are forced by the family members. But towards the end, after you completing your program, either you are in the midwife or nursing program, you must ask yourself what you want in your life. So first of all, you need to build up what actually your objective, what you goal. So if you are in the midwife area of nursing area, so you must come up with the objective or goal that I want to ensure that the community is enhanced in terms of their health status. So when we have mind of that, so our intervention, our practice, our behavior also will be parallel with whatever that we try to achieve. So means that you are trying to give your best. There's no shortcuts during the intervention. Okay, why nurses is doing the shortcut during intervention? Because they are not understand what actually the complication, what actually benefit towards the patient itself of the mother. So when they know in depth about their activity, what they are doing, the rationale behind of that, for sure you will have an idea. I must do this. I must ensure that I must avoid, I must prevent. That will become what in our mind. So I'm sure that if you understand well about yourself, you need to ask about yourself, because we are dealing with the life of the people. We are not dealing with the things. If you think I don't mind, but we are dealing about the people life. So when you are dealing with the people life, you are dealing with the risk, the consequences, whatever that you done. So during the study, maybe you have the clinical instructor who are with you, but when you are works, so it's your responsible, it's your accountable to whatever that you done. So means that whatever that you done must be is research based, evidence based. It must be the current, it must be follow the standard operational procedure. So means that you are not far from the what has been planned for the management of the patient.
Okay, thank you for the insightful suggestions. We hope that our students understand about what you've already said. Unfortunately, no one is raising their hands. Once again, I will call all the students who has a question. Please join us today. Raise your hand. Actually, in Indonesia, we has a similar ways in facing these issues. For the monitoring and early detection, we has a program named Posyandu Terintegrasi. It's actually quite new here in Indonesia to be applied, so it's still processing. We cannot really measure the outcome yet, but it's hopefully can reduce this maternal mortality significantly. And for the antenatal care, we has puskesmas, the first this primary care, yeah. But yeah, we face a lot of challenges. For instance, the limited resources, limited awareness, especially in the underserved areas, like in the villages. And also we face the same culture, like misperception culture. A lot of mother still believe in mythos. How to
Yeah.
say? Yeah. Okay. There's a question here in the Ananda. Okay. Aninda Nursakina from nursing program. The question is there a way to reduce the risk of death in pregnant women that already old, that has a high risk of pregnancy? And what should be done if there is a woman who wants to have children at an old age? Maybe because of they still don't have any child, so they keep trying as they get older, so they still want to have a children. And is there a certain way to reduce the risk of death in pregnant women?
Okay, thank you. So how old that woman's actually?
Yeah.
Okay, so we also have the same problems. So for those partner doesn't have any children at all, and the age of the mother already 42, 43. So and then they are get pregnant. So we consider this as a precious baby. So for those the special case like this, we allow for the pregnancy because we understand the needs of the parents itself, how long they are waiting for this baby. When we identify this is a risk factor, so we need to really close monitoring for the mother. We need to understand that during this age, mother is really fatigued, easily lethargy. So we advise mother to have a lot of the rest to ensure that it's give opportunity for the body of the mother itself and also the development of the baby itself. And also we need to really ensure that mother is understand what will be the complication that might be occur throughout the pregnancy. Okay, so the first, we advise mother if they are working for the first trimester and also up to the second trimester, we try to avoid heavy duty job for the mother. We advise mother, maybe if you are lacking, you are lethargy, maybe you just take a rest leave, annual leave. This is needed by the age of the mother itself. And also when it's come to the second trimester and also up to the third trimester, basically it's preparation for the delivery. So the mother itself must be understand what will be the complication and what they need to monitor. Okay, start from the 28 weeks. So the mother must start for counting the kick chart movement of the baby. So they need to already understand. We don't expect that, oh, patient already 42, they should know this. No, patient doesn't have any experience before. So as a midwife, we must ensure that the mother is understand well how to count this movement, fatigue chart. From the fatigue chart also, we can monitor the progress of pregnancy and also the well-being of the infant, the baby itself. So when the mother understand the importance of this, the importance of take care of the himself or herself itself, so it contribute to the successful during the delivery itself. So because the mentality preparation, physical preparations, so this also contribute to the success of the labor and also management for the postpartum period. So back to the question just now, is it age is relative with this condition? So we'll look at the cases. So some cases, patient is having child every 10 years. The gap, every 10 years. So even regardless the age of the mother, so we allow for the pregnancy, but we emphasize about what might be the complication or the problem might be occur. Mother need to really understand. They need to know what to do if something is not in place. They need to come to the hospital immediately for the treatments. Okay.
Ya, baik. Jadi yang pertama adalah monitoring dan pendampingan. Pastikan ibu tersebut memahami bagaimana kondisinya saat ini supaya meningkatkan kesadaran. Jika ibunya mengetahui apa saja resikonya, apa yang harus dilakukan, maka kesadaran untuk menjaga diri sendiri dan bayinya untuk datang ke fasilitas kesehatan juga akan meningkat supaya kehamilannya menjadi aman dan terkontrol. Begitu pula untuk manajemen postpartum. Begitu, Ananda Nur Sakina, apakah bisa dilanjutkan? Saya? Oke. Move into the next question, Mrs. Rohima. Okay. Nah, there is question from Saiful Anwar. Assalamualaikum, Mrs. My introduction is my name is Saiful Anwar from Kotabumi Nursing Program. The question is, how do we respond to the growing technology trends in the world of health for mothers? However, the society has difficulty to access the service. How can we as health service providers continue to provide the best health service to the mother? Regarding the technology that not every mother has the access to the technology. Thank you.
Yeah. Okay. So thank you for the questions. Okay. So the question is about the technology use and not all mother have the technology. And the second one is how they reach for the facilities. So these two different things. So I answer the first question about the technology. So I'm sure that nowadays everyone have the phones. Okay, they can access whatever they want to know about themselves. For example, I said, oh, you have the hypertension during the pregnancy. They can Google up. So what actually hypertension? What actually the complication? What the impact to the mother, herself, and also for the baby? They can read. But they can connect what the physiology changes behind of the disease itself. So as a midwife, that is our roles to ensure that the information that patient get from the technology, information from the internet is the latest and the current one. And from the information they get, So midwives must make sure that the mother is understand whatever that they read from the information from the internet. So because internet there is a pro and cons. Some information is very good. Some information is not benefit at all for the patient. So we must ensure that our customer or stakeholder or the mother itself know how to choose which one is the right information that they can use for themselves. But as a midwife, we must ensure that they understand what actually the link, because they don't have any basic of the medical. They can read a lot. This Google said this said this, but you as a healthcare provider who know better in your field, you must ensure that the mother is understand what will be the benefit, the complication, the implications, the harsh, and also everything for the mother. The second one is about the technology. I don't know about the others country. In Malaysia, we have the system where the appointments based on the phone. So we are having the appointment reminder. So this to cater to ensure that the mother come to the hospital or to the clinic according to the appointment, so that we can monitor the progress of the mother. For those who doesn't have the phone and so on, so we still go to the basic method, which is the appointment is still in the appointment card. Other than that, the midwife basically a day before of the appointment, they already call the mother or reach to the mother to remind them that, oh, tomorrow you have the appointment with me, to make sure that you come. Either you can come in the morning session or maybe you can come to afternoon session, just to ensure that they're aware, because mother is very busy at house with their other children, maybe they are working. So this light reminder is benefit for the patient to ensure that they come obey with the appointment. Okay, the second one about the access to the healthcare facilities. So access of the facilities actually is likely related with the technology just now. I said about the reminder through the appointment application. That's for those with the phone. For the others without the phone, we still go to the basic method just now. It's about the card appointment, antenatal card appointment, and also phone call or visit to the house if the patient can't come to the healthcare facilities. So still have the midwife go using the motorcycle to reach them and ask why you didn't come. So some said that they have no time, there's no transport. So that's how we are trying to settle to solve the problems on reaching to the healthcare facility. So we go to the mothers.
Yeah.
Okay.
Similar program has already applied here in Indonesia. We have pendampingan kader posyandu. Yeah, sometimes the mother needs to be visited to ensure their safety and their health to home service at their home. Okay, thank you, Miss Rahima. The next question, the last question from Ibu Islamiati, a lecturer in midwifery program in Metro. The question is, are there special factors that cause difference in maternal mortality in various countries? And is this related to factors, to specific factors that including maternal habits in each country?
Okay, the features.
Yeah.
Okay. Okay, so we look back to the question just now. It's about the features on the developing country and also the others country. So the difference between both actually is relate to what the facilities prepared by the government for the mother and child healthcare. So some of the country with a small population, maybe small in the scale of the geographical, they can supply with the adequate healthcare facilities. Compare those government or country with the large geographical map scale and also population with the huge. So it's quite challenging to prepare for the access for the healthcare facilities. So what the difference between this is actually is reflect back to this, the delay of the model. So when you are in the area country that large capacity, so they must have a delay. If they are not preparing the nearest healthcare facilities, is delay in reaching mother to reach to the facilities. When we compare to the nearest, the other country who are small and access to the facility is near, so we can see that the level of the maternal deaths is reducing because of this. Because we already cut the time to reach, we already cut the expert, so we are preparing, we are invest on the manpower, all the manpower, all the expert we supply to those, even the clinic itself, we have the doctor to cater some basic mild alignments of the mother, or maybe some cases of the stable condition of the hypertension, preeclampsia also can be managed at the primary care. But when it comes to the severe cases or uncontrolled cases, we need to refer to the secondary. So we need to look back at both countries. Either these primary, secondary, and tertiary facilities is in place or not. If in place, either is adequate enough or not to cater the total population of the patients there. So basically, the difference between this is about this, the facilities, the manpower, and also expert, the transportation. So all this must be invest. Government must be invest in maternal and child, including to the transportation and so on, so that we can cut every factor that can cause delay to reaching to the facilities.
Thank you, Miss. So the support for the government through the policies is really indeed needed, in the term of decreasing this issue. Okay, we have one student raise the hand. Could you please turn on your camera, Miss Izzatul Muslimah?
Okay, Miss, first of all, I would like to apologize if my video is not live due
Okay.
to problem with the cell phone I'm using.
It's okay.
Okay.
Okay, before that, was my voice heard, Miss?
Yeah, I can hear your voice clearly.
Okay, let me introduce myself. My name is Izzatul Muslimah from level 2 regular 1 from Kotabumi Nursing. Okay, the question is, as a nursing student who is going into semester 4, what should I do to deal with the problem of maternal mortality when I carry out clinical practice and encounter aggressive patient families?
Okay, we have a special patient, a special family that is quite aggressive. How we might have the intervention clear, or the intervention if we have such a family like that. Is that correct, Miss Izzatul?
Yes, Miss.
Yeah.
Okay. So it's back to the culture perception and also the health belief of the family itself or the personnel itself. So how they believe on their health. Might be this family thinks that they are healthy. They doesn't have to access for the help from the others for medical, so they can manage by themselves. So as a healthcare provider or as a student nurse, you as student nurse are dealing with the cases, we must ensure that we understand this problem. This will be the barrier in our courses. When we know this, don't try to avoid from the family. I'm sure that they are using the harsh word against you. You are not happy dealing with them. But that actually is the nature of the nurses. Okay, jangan sedih. Okay, jangan sedih. We still need to deal. Whatever, regardless the background of the family, our goal actually is to ensure that they are safe. We enhance the health status of the family. So how we want to do this? So first, we need to understand the culture or the health belief of the family itself. Try to understand, try to ask what they are concerned, what they understand. So how we can support this family by true understanding of the family matter. Okay, they understand about the health, what they are concerned, and then you try to build a rapport with them, what we can contribute to ensure that together with their belief, it also can enhance their health status. Okay, for example, they said that they can manage. They want to do the home delivery, for example. Family members said that every members in the family is delivered in home. So our contributions to this family might be we need to deal. So check, is there any history, complication from the previous delivery at home of the family members? And then check who conduct the delivery process. Okay, try to get information how far the understanding, the expertise of the person that's conduct the delivery. Okay, and then after that, we try to understand, try to make the patient and family understand, which is either the practice is safe or not for this pregnancy, because every pregnancy they have the special condition. If the patient doesn't have any complication, which is fulfill the criteria to home delivery, might be you can allow for the home delivery. But if the throughout the assessment, you identify that patient is having risk, for example, even the risk is 2%, 3%, it's still risk. The risk can be increased throughout the process. So as a healthcare provider, we don't want any percentage of this risk can be occur. So we need to prevent it as early as possible. So if the family members still want to deliver at home, might be what we can do, madam, it might be why not I'm there together with your person who conduct the delivery. I'm there to monitor. I'm there to assist if anything happen. So for that approach, I'm sure that we are still understand, respect their belief and culture, and also towards the end, also we are implement what the must that we do to the patient to ensure that the safety of the patient. So that's how we can do. I'm not sure Indonesia, is it still allowed for the home delivery?
No, it's not.
It's not. So it's our challenge basically to educate people on the needs, the importance of the delivered at the hospital. So because of the facilities itself. Okay, so for that cases, I'm sure that you need to a long way to adapt, to approach the family, to make them understand, and so on.
Terima kasih. Jadi perawat dan jadi bidan itu harus kuat gitu ya. To be a nurse and to be a midwife needs to have a strong mental ya.
Yeah.
Yeah. Mrs. Izatu, do you have any feedback? Kak Izatu,
Yeah, Miss.
do you have any feedback?
I think so. Thank you for answer.
Okay, thank you. Yeah. Thank you for all participants for your thoughtful question and engagement, and to Madam Rahima for providing such a comprehensive response. We are gladly to have you today in this lecturing session, and we hope to see you again. We will invite you in the next time to come here to Lampung to see our beautiful seas.
Inshallah.
Hope to see you soon. And to conclude this session, we have learned about the crucial role of comprehensive midwifery service in reducing maternal mortality. The strategies and insights shared today will undoubtedly contribute to advancing global maternal health, especially in Indonesia. On that note, this concludes our expert lecture. Thank you, Mrs. Rahima. And I would like to extend my gratitude to Madam and for your for your valuable time and expertise to share here. And thank you for all the participants. I'm so sorry for all shortcomings, and I return the floor to our master ceremonies. Thank you.
Okay.
All right. Thank you very much, Madam Rahima, and Mr. Rovana for leading such an insightful and engaging session. Okay, we will now move on to the next nursing session, which will be moderated by Mr. Wimba Widakdo Dinutanayo, Master of Science. And for Mr. Wimba, the time is yours.
Okay, thank you, Taskia. Maybe for Madam Rahima, could you please? Yeah, thank you so much. Good morning, everyone. Do we have Madam Sri here?
Yeah, I'm here.
Oh, yeah. Okay, Pak Hadi, could you spotlight here? Okay. Good morning, everyone. Let me introduce myself first. My name is Wimba. I will be your moderator for this session with Madam Sri Wahyuni Azhar. She is senior lecturer in Management and Science University, Malaysia. The topic that will be explained by Madam Sri Wahyuni is nursing care for home care services for stroke patient. Before we begin, let me read first the curriculum vitae of Madam Sri Wahyuni. Okay, so Madam Sri Wahyuni binti Azhar obtained her education in University Teknologi Mara UTM Malaysia in 2021 for Master of Nursing, and then she also attended Bachelor of Nursing Science in Open University Malaysia, and now she is a lecturer in MSU. Start from July this year until now. But before she works in MSU, she already a senior lecturer in some of the colleagues in Department of Nursing. How are you, Madam Sri Wahyuni?
Alhamdulillah, sehat.
Sehat, Alhamdulillah. Actually, we have in this meeting the students from Department of Nursing. So we have three study program. First, diploma 3 or associate degree, and then the second one is Bachelor of Applied Science for nursing, and then the third one is nurse profession. And then for the location itself, for diploma 3 or associate degree, we have in two location in Bandar Lampung. Bandar Lampung is the capital city of Lampung province, and then also in Kotabumi. Kotabumi is around maybe 6 hours from Bandar Lampung. I hope you one day you will have an opportunity to come to our city, and then yeah, just we will welcome you. Okay, without further ado, please you can start your presentation.
Okay. Assalamualaikum and good morning. Okay. It is an honor to be here today to talk about a topic that touch the life of many individuals and families. Yeah. And nursing care for stroke patient in the home care setting. Okay. Stroke actually is a life-altering event, not only for the patient but also their loved one. Okay. It's require a holistic approach that encompasses medical, physical, emotional, and social support to achieve the best possible recovery outcome. Okay, so today, I will share about you the nursing care for home care service for stroke patient. Okay, so let me share my slide. Okay, can you see my slide?
Yeah, it's already.
Right. Okay. So, okay, let me proceed. Okay. So, okay, this is our outcome for today. Okay, by the end of this session, participants will be able to understand the comprehensive role of home care nursing. Okay. Okay, for stroke patient, apply evidence-based practice to enhance recovery outcome. Okay, and then utilize technology and tools to improve patients' monitoring. Then provide psychosocial and emotional support for patient and caregivers. Okay, educate caregiver effectively to promote patient independence. Okay, as we know, okay, stroke is not only involve the patient but also the caregiver, because it will affect the physical, emotional, psychosocial, financial, and etc. Okay. So for introduction, actually, in World Health Organization 2019, okay, actually stroke is one of the leading cause of disability, okay, often leaving survivor with physical, emotional, and cognitive challenge. Effective home care nursing provide a bridge from hospital care to recovery home, okay, and so which is based on the data 2019, China is the highest incident of stroke. Okay. Yeah. As for Malaysia, stroke is the third cerebral vascular disease in the death of Malaysian people. Okay. And then for Indonesia, based on 2019 data as well, they said that cerebral vascular disease is the second most common cause of the death in the Indonesia after COVID-19. Okay, right. So let we see what the impact of the stroke to the patient and the caregiver. Okay, as I mentioned before, stroke involve physical, cognitive, emotional, and social. Okay. Okay. So for physical, okay, we know that patient stroke, they're mostly paralyzed one side of their body. Okay. It inhibit them from do a normal activity of daily living. Okay, such as eat, okay, walking, talking, yeah, and then especially when they cannot go to work. Okay. It definitely will affect their physical movement, okay, because they will involve the paralysis, loss of motor skill, Okay, let's say previously they can walk, okay, they can do anything by themselves, but now they need to dependent on others. Okay, and difficulty and mobility, definitely they cannot walk by themselves, they cannot eat by themselves, even they cannot go to work as a normal person. Okay, so what is the impact of the physical challenge to this stroke patient? Okay, especially when they are the breadwinner of the family. Okay, definitely it will cause a financial problem. Okay, who will taking care, who are going to get financial for the family. Okay, so this is more or less will cause the emotional effect, which is the increase of risk of depression, anxiety, okay, then emotional instability. Okay, depression because of what? Okay, everything we need money. Okay, you want to eat also you need money. Even though you want to do something, even though you want to reach a taxi, okay, you want to do anything that we need money. So let's imagine if you cannot go to work, cannot give a financial support for your family as usual. Definitely it can cause the depression, right? And then it also can cause frustration, anger, okay? Okay, indirectly it will affect the social interaction, social relationship, okay? For the patient itself, she or he will feel that he will cause burden to the caregiver. He will be the burden to the family. Okay, because of what? Everything also need to depend on the other people. Okay, even want to eat, you need somebody to feed you. Okay, and then strain on the relationship. Maybe at this time the patient will isolate themselves. Okay, feel frustration, feel angry. Okay, feel asking why this happened to me, why nobody else. Okay, why I have to face this situation. Okay, so of course we as a caregiver, as a nurses, as a family, as a friends need to play a special role for this kind of patient. Okay, so other than that, the impact of stroke is cognitive. Okay, so where there is challenge in speech. Okay, the patient cannot speak properly as usual. Okay, so sometimes we cannot understand what patient try to say, what patient try to communicate with you. So the communication breakdown will happen here. Then it can cause also memory problem. Okay, and of course it can affect decision making, right? Okay, next. So what is role of home care nursing? Okay, there's difference between home care nursing and hospital. Okay, so home care nursing is after the hospital. This is a tertiary care. Okay, so the roles is the bridging the gap between hospital and home. What does that mean? Okay, so let's say during in the hospital stay, okay, during the admission to the hospital, okay, the nurses, the doctor will taking care of the patient. Okay, will taking care of this stroke patient. Okay, there is everyday routine is taking care of the patient. Okay, such as bed the patient. Okay, as give the patient food. Okay, give the medicine on time. Okay, access for vital sign from head to toe. Okay, so in the home care setting, they're supposed to continuing of the hospital management. Okay, there are supposed no gap between the hospital and the home care. So how are we going to make it happen? Okay, of course, we have to provide education to the family member and also the caregiver. Okay, the education can be in terms of how to giving food, okay, when to take the medicine, okay, how to take the vital sign and how to record it, and how to differentiate between the normal one and the abnormal one, okay? Because we will, before the discharge, we will provide the personalized care tailored to the patient's need, okay, in terms of everything, okay, in terms of their diet, okay, in terms of their medicine, in terms of their life care, okay, ensuring continuity of care through regular monitoring and support, okay, acting as a source of education empowerment for patient and caregiver, okay. Before we leave patient for discharge home, okay, we will teach the caregiver in terms of the sign and symptom of recurrent stroke, okay, and then how to taking care of and then how to make a patient as like before, okay, in terms of occupational therapy, in terms of their lifestyle, okay. Okay, so next one is to monitor the vital signs, okay, such as their blood pressure, okay, their temperature, their respiratory rate, okay. So we need to educate the caregiver in terms of the normal and abnormal one. So do with the neurological status. Okay, we teach about is the patient alert, orientated, okay? So is the patient feel dizzy? Okay, so we will teach the caregiver in terms of the detecting of abnormal. Okay, one. Okay, administering medicine and coordinating with healthcare provider. Okay, so before patient discharge, we will teach the caregiver about the medicine. Okay, about the dosage. Okay, about the time. Okay, and then about the side effect of the medicine. Okay, and then what happen if patients skip their medicine? And then also, we teach also the caregiver on how to report to the healthcare provider, just in case they detect any abnormality. Okay. Next one is managing nutrition, hydration, and personal hygiene. Okay. So at this stage, patient need the very nutritious nutrition. Okay. The balanced one. Okay. They consist of protein, yeah, vitamin, mineral, carbohydrate to promote their ability to being better. Okay, hydration, make sure patient get enough water. Okay, and then of course, because patient cannot do their own ADL, we as a caregiver or the family member need to emphasize on the personal hygiene, on how to getting bath, okay, how to go for toilet, and etc. Okay. So next one is educating patient on rehabilitation goals and progress. Okay, so we teach the family member, okay, to record every single thing that they do every day. Okay, what did they take, and then what is their progress. Okay, let's say for today, patient can move their hand, move their finger. So next day or maybe next week, they can raise their hand. Okay, so slowly we will teach patient, okay, teach the caregiver, and keep on give support to the family as well, right? So for rehabilitation support, physical therapy, assisting with exercise to strengthen muscle and improve mobility. Okay, we can give patient a ball, okay, to exercise, okay, to stimulate the muscle, okay, and as well to the brain. Okay, so it will cooperate with the brain. So next one is we can teach patient on how to walk, okay, using the walking frame. Okay, so keep on encouraging the use of mobility aid like a walker or brace. Then the next one is teaching patient and caregiver technique for safe transfer and movement, especially from bed to chairs, and to chairs from the wheelchair to the bed. Okay, so we have to teach them how to transfer safely. Okay, and then promote the integrating of physical activity into daily routine. Okay, that's mean, okay, we need to teach patient, okay, on where the normally you put their thing, yeah, their personal things, so it can make them used to it, right? So the next one is activity, okay, activity of daily living. Okay, so what is activity of daily living? Okay, about the eating, okay, toileting, how to wear clothes. Okay, all right. So so focusing on self-care tasks such as bathing, dressing, and grooming. Okay, building routine to enhance patient independence. Okay, this is important because of what? This will increase the patient's self-esteem. Okay, so later on, patient will feel that he can do it by themselves. Okay, so they will feel that they lessen the burden to their caregiver. Okay, adapting the home environment to ensure safety and accessibility. Okay, just like I mentioned before, we educate patient, okay, to make patient get used to the where their personal belonging location. Okay, and about where is the toilet, where is the bed, okay, where to take their clothes, okay, and then so on. Encourage patient to take an activity role in their recovery. Okay, so you let them get involved in any activity. Okay, so they will gain the cooperation from the patient. Okay, and it will help in their recovery. Okay, so that will make patient feel better. Okay, psychosocial and emotional care challenge. Okay, so here we can recognize the sign of depression and emotional distress. Okay, so here, okay, we need to, because we know that patient feel depression, feel angry, so of course they have a emotional distress. So as a caregiver, we have to understand how to recognize this sign of depression. Okay, such as patient try to isolate themselves, no eye contact. Okay, patient reduce communication. Okay, doesn't want to talk, doesn't want to share their feeling. Okay, and suddenly you can see patient crying alone. Okay, when you ask, they say that there's nothing. Okay, so they don't want to share with you anything. Okay, they try to isolate themselves, withdraw from any activity. Okay, so don't want to get involved in any activity, and try to avoid any communication. Okay, that is the sign of depression. And sometimes maybe patient will say that I don't want to live anymore. I don't want to be a burden to family. I don't want to be a burden to any other caregiver. So that is the sign of depression. So as a caregiver or family member, we have to alert on this sign and symptom, right? The next one is managing anxiety and fear related to recovery. Okay, sometimes patient will feel that there are no use for me to get involved in this thing. After all, I will depend on others to live, okay, to eat, to walk. Okay, so we as family member, as a caregiver, we need to give emotional support. Okay, keep on, because sometimes we as caregiver as well need a emotional support. Okay, sometimes we also burn out, but we have to convince the patient, okay, give a support, give a moral support, and encouraging them to take any what decision in their nursing care. All right. Right. Addressing social isolation through community and family involvement. So we make sure that patient will get involved in any activity. Okay, and so we can refer, okay, family member and the caregiver. For example, in Malaysia, we have a Malaysia Stroke Council, okay, and National Stroke Association of Malaysia, or NASAM. Okay, they will give full information about the stroke patient, about the recognition of stroke, about the management of the stroke. Then they also have an activity. Okay, every year they have activity. So when patient get involved in the social activity, maybe more or less they will reduce their stress, and they feel that he is not alone. Okay, somebody else also face the same thing with them. Okay, they also have detail or more information about the stroke in their website of Malaysia Stroke Council and National Stroke Association of Malaysia, right? Okay. So next is patient and caregiver education. Okay, teaching caregiver about stroke management and complication prevention. Okay, here we will teach the caregiver about the recognition of the stroke, how to detect early sign of stroke. Okay, let's say okay, this is, we use an acronym FAST, F-A-S-T. Okay, F is for face drooping. Okay, when you see the patient face, okay, you can see that the face is not symmetry or drooping. Okay, one side is drooping. Okay, so how to recognize whether the face of drooping or not? So first thing is you ask patient to smile. Okay, so if patient can smile, means that the face is okay, but the smile is, one is drooping and one is going up. So that is sign of first sign of stroke. Okay, the next one is arm weakness. Okay, their drift down. Okay, one hand is drift down. Okay, so what you have to do, how to check it, you ask patient to raise their both hand. Okay, so if symmetry means if the patient can raise their both hand, so means they are okay. But when the condition is one is drifting out, okay, drifting down, so but one is can maintain, so that means there is sign of stroke. Okay, the next one is speech difficulty. So how to detect or how to make sure that patient having stroke or not? Okay, we ask patient to make a simple sentence. Okay, let's say, hi, my name is Sri. Okay, so normally when patient have a sign of stroke, they cannot complete the full sentence, right? Okay, the next one is time. Okay, T is the time. Okay, let's say the rest for the FAS just now, you detect the patient have a sign and symptom of the stroke. Okay, so the time is very precious here. So you must, if you notice all that thing, okay, you have to report to the emergency services. So you can call ambulance and report the time the thing happened. Okay, and of course you have to report your location. Okay, so maybe you have to bring patient to the nearest hospital or waiting for ambulance. Okay, so next one is educating on the importance of medication adherence and regular follow-up. Means that patient need go for their follow-up as scheduled. Okay, so for rehabilitation, yeah, and to take a medicine. So there, you must emphasize to the caregiver on the importance, okay, of the follow-up and the importance of taking a regular medicine. Okay, the next one is providing nutritional guidance to support recovery. Okay, normally before patients going for discharge, dietitian will calculate what amount of calorie, what intake, what their daily intake they're supposed to take. Okay. And then so the caregiver can do cooking based on their diet need. Okay. Based on their nutritional need. Okay. Next one is encouraging lifestyle change such as smoking cessation and exercise. Okay, this is very important because of, okay, patient have to try to stop smoking or try to reduce the smoking because smoking will affect their health. Okay, and then we also can encourage patient to do a simple exercise, help them on the okay, in the exercise. Okay, so next one is use of technology in home care. Okay, so here is we can use leveraging telehealth for remote consulting and monitoring. Okay, so what is this? A process using mobile health application. Okay, so here we can do the appointment. Okay, patient health tracking and reminder of the when to take the medicine, when to go for appointment, okay, when to go for rehabilitation, when to do when go to the exercise session, right? And then so what is the benefit of the telehealth is to increase accessibility to healthcare professional, okay, enhance monitoring for early intervention, okay. So, so what is the monitoring progress? Okay, regulation, evaluation to adjust care plan based on patients' need. Okay. Okay, it's also enhancing accessibility to expert care through virtual platform. All right. Okay, next one is quality improvement and patient's outcome. Okay, conducting regular evaluation to adjust the care plan. Okay, let's say we already plan for patient. Okay, so from day to day we will evaluate based on our nursing process. Okay, which is we have to we are their ADPI. Okay, assessment. Okay, diagnosis, planning, implementation, and evaluation. So after we go through all the care plan, after that we have to evaluate is it our care plan is good or not, is it meet our objective or not. Okay, if okay we just proceed, and if not okay we need to adjust our care plan based on patient's need. Okay, next one is setting measurable goal for physical and emotional recovery. Okay, tracking progress through patient feedback and health metric, and fostering a collaborative approach to ensure optimal outcome. Okay, let's say we have to refer patient for another session of occupational therapy. Okay, let's say after some time patient is going better, so we will refer patient to the occupational therapy. Okay, as a preparation for patient going back to work. Okay. All right. So, as a conclusion, okay, home care nursing for stroke patient is a multi-dimensional practice that demands both technical expertise and compassionate care. Okay. Home care nursing for stroke patient is a technical expertise and compassionate care by embracing evidence-based approach and leveraging technology. Nurses can significantly improve recovery, outcome, and quality of the life for stroke survivor, and also as for the caregiver. Okay, home care nursing play a crucial role, okay, in the recovery journey of stroke patient, which is it involves not just physical care but also emotional and educational support to the patient and caregiver by leveraging technology and fostering a patient-centered approach. Nurses can significantly enhance the quality of life and recovery outcome for stroke survivor. Okay, this holistic approach ensure that recovery extends beyond medical intervention, empowering patients to regain independent. So our objective here is to make patients get back to the normal life as we can. Okay. So that's all our my lecture for today. Get back to Wimba.
Yeah, okay. Thank you so much, Madam Sri. Now we will start the Q&A session. For all of the participants or audiences who has a question, please just shout out in this Zoom, or you can type in Zoom chat and I will read for you. Okay, the first one we have a question from Dinda Gusti. Hello, my name is Dinda Gusti Aliani. Her question is how nurses overcome the challenges of caring for stroke patients at home, especially when patients have limited mobility. When we want to adapt to the home environment, the use of assistive technology or effective communication strategies with these patients. Okay, I think there is some questions that thrown by her. First one is how nurses overcome the challenges of caring for stroke patients at home, especially the stroke patients who has limited mobility. Maybe you can answer that first question.
Okay.
Yeah.
So the first one is they're asking about how to overcome the challenges.
The challenges, yeah.
The challenges. Okay. So the next one is caring for stroke patient at home. Isn't it?
Maybe you can answer the first question first.
Okay. For the first
How
one
to
is
overcome the challenges for caring stroke patients. Maybe as a student, she doesn't know yet the challenges of caring for uh stroke patient. Maybe you can explain first the technical challenges that facing by the home care nurse, and then how to deal with it.
okay. Thank you so much for the question. Okay, I will answer. The first one is challenging of caring stroke patient in terms of technical and emotional, right? So the challenges is, okay, you have to understand that stroke patient definitely will rely 100% on you. Okay, that is the first challenges. Okay, so you have to know how to taking care of the patient. Okay, we understand that patient cannot do their activity of daily living. Okay, they cannot definitely almost 100% they will rely on you. So of course you have to know. So the first challenge is technically you have to schedule and plan what the best nursing care for this patient. Okay, so you have taking care. You have to plan. Okay, what to do. Okay, first one, in the morning what you have to do. Okay, in the evening what you have to do, and then the evening what you have to do. Okay. Okay, let's say, okay, you have to schedule for morning, you have to make sure patient getting back. Okay, patient will take their breakfast, will take their medicine. Okay, will go for their exercise. Okay, so we'll schedule. We will do based on your schedule, based on your plan. Okay. Okay, that one is in terms of technically as a nurses. Okay, the next one is emotional. You must get ready in terms of you are dealing with the patient that angry, dealing with the patient that frustrated. Definitely, you will have a language barrier, you will have a communication barrier. So you yourself have to prepare mentally and emotionally how to taking care this kind of patient. Okay, so definitely you have need to be patient more. Okay. Okay. Okay, that's one is the first question. Okay, the next one is caring for stroke patient. Actually, the question is more or less the same. Okay, caring, taking
Madam
care of
Sri,
the patient. So I think
yeah,
I
sorry,
already,
Madam Sri.
yeah.
Yeah, could I translate first your answer? Maybe she don't really understand in English, so I will translate first your
Sisiran ya, Ting, kakaknya, Ting.
answer. Ya, oke. Untuk audiens lain, tadi Dinda menanyakan bahwa bagaimana kita menangani tantangan selama menangani pasien stroke di rumah, terutama pasien-pasien yang punya keterbatasan mobilitas. Nah, Madam Sri tadi uh, menjawab bahwa yang harus kita ingat, pasien itu sangat bergantung kepada kita. Pasien itu sangat dependen kepada kita. Jadi kita harus selalu siap, terutama di dua aspek. Yang pertama aspek teknis, yang kedua aspek emosional atau emosi. Bagaimana cara menanganinya? Yang pertama untuk aspek teknis, pastikan bahwa kita membuat jadwal dan rencana. Misalnya jadwalnya dari pagi sampai sore, maka kalian harus benar-benar bisa menjadwalkan secara jelas apa yang mau kalian lakukan dari pagi sampai sore. Misalnya jam 8 pagi mau ngapain, jam 8 sampai setengah 9 mau apa, setengah 9 sampai 10 mau apa gitu. Karena benar-benar pasien itu bergantung kepada kita gitu. Karena mobilitasnya terbatas gitu. Jadi harus rencanakan dan jadwalkan perawatan terbaik untuk si pasiennya. Jadi harus bikin to-do list. Yang kedua adalah kita harus bersiap uh, untuk kita menghadapi kemarahan dan frustasi karena pasien stroke itu uh, pasti penuh dengan kemarahan dan frustasi karena biasanya bisa bergerak bebas, ini jadi terbatas gitu. Nah, dan ini bakal jadi keterbatasan komunikasi kita dengan pasien. Jadi kalian harus siap secara mental. Mungkin seperti itu. Madam Sri, actually you can also answer in Melayu. So
Sure,
they
can.
will yeah, just mix in English and Melayu. Okay, like what you said, the second question is more or less same with the first question, but it is include the technology and communication strategies. How we use technology for caring the stroke patient in home.
Okay, you're asking me about the how to use the technology, isn't it?
Yeah.
Okay. Okay. First of all, in terms of taking care of patient in the home, okay, we can use actually in the home technology that we can use is about the apps. Okay. Okay. For example, the appointment apps. Okay. Then the reminder. Okay. Okay. Let's say you can setting. Okay. When you are going to taking the medicine. Okay. When you are going for your next appointment. Okay. And then when you are going for exercise. Okay. So what nutrition, okay, what diet that you need to take for that day. Okay. So what is your objective? So I think there is app that can monitor, okay, also your dietary intake. Okay. So for technology, I think it's more for the apps. Okay, so maybe in the rehabilitation center, maybe they can use some machinery to help on positioning the patient, to lift up the patient. Okay, for if we bring out that thing to the house, or maybe there is quite expensive unless you are in the home care. Okay, that's all. I hope it answer your questions.
Yeah. Jadi teknologi yang dipakai biasanya berbentuk aplikasi atau app. App ini nanti isinya bisa appointment atau janji ketemu atau janji perawatan, kemudian juga bisa reminder atau pengingat pasien itu harus ngapain. Kemudian terkait dengan diet juga, kebutuhan nutrisinya harus bagaimana, itu sebenarnya udah banyak aplikasi terkait dengan itu ya. Kemudian satu lagi mungkin teknologi yang bisa dilakukan adalah mesin rehabilitasi, walaupun pasti itu mahal dan sulit gitu ya kalau untuk harus dibawa ke rumah gitu kira-kira. Okay, the last question from Dinda is, do you think there is a significant difference in recovery for stroke patient between patient who has home service and patient who care in hospital?
Okay. So you're asking about the difference between rehabilitation of
Yeah,
the patient stroke in the
yeah,
hospital and nursing care. Is
yeah,
that
true.
is that true?
Yeah, yeah,
Okay.
true.
All right. So actually the difference is the hospital setting and home care setting. Okay. As we know that hospital we have all the healthcare provider, all the healthcare professional such as doctor, nurses, okay, radiographer, physiotherapists, and so on. Okay, definitely, if you ask about the difference between hospital and home care setting, of course, the hospital is the best place. Okay, but for recovery thing, okay, because in the hospital we are focusing on how, okay, to treat the patient. Okay, so we want to treat the patient. So in the home care we are focusing on how to make patient back to their normal life. So it's focusing on rehabilitation. Okay, so if you're asking me about the difference between these two, okay, the first one is hospital is to treat and the home care setting is to rehabilitate. So after there are patient, the doctor and the hospital staff nurses done with their task in the hospital, okay, means that they are going to treat the patient. So if patient is getting better and able to taking care of their self or can proceed to the tertiary, which is a home care setting. Okay, so macam mana nak cakap? Okay, so hospital is focused on treating the patient. So if you ask me, both is play rules. The both is play role for and also the both also have their own objective. Okay, misal kata, okay, saya terangkan, okay, kalau pesakit sudah sembuh di hospital, okay, selalunya doktor akan bagi patient pulang ke rumah, okay. So, tapi dalam masa yang sama, patient perlu dipastikan ataupun sebagai caregiver mereka perlu memastikan yang pesakit itu dapat memenuhi dia punya keperluan hidup seharian dia. Contohnya patient perlu makan, patient perlukan exercise, okay? Patient perlu ada seseorang yang mengingatkan dia untuk makan ubat, okay? Perlukan seseorang yang taking care of their patients. Okay, so kalau home care is, we can say the tertiary care. Okay. So, am I answering your question?
Oke, Dinda, bagaimana? Ada Dinda di sini. So, objektifnya atau goalnya berbeda antara rumah sakit dan juga perawatan di rumah ya. Kalau di rumah sakit itu goalnya lebih kepada merawat pasien, sedangkan di rumah itu lebih ke rehabilitasi. Jadi pasti karena objeknya berbeda pasti juga karena tujuannya berbeda juga pasti hasilnya nanti akan berbeda juga gitu ya. But I have a question. Is there any rehabilitation service in hospital
Yeah,
for
they
stroke
have.
patients?
They have
Yeah, but with
rehabilitation, but
Mm,
of course, not as they are not focusing. Actually, okay, they in the hospital they have rehabilitation center. Okay, so let's say they can treat patient, inpatient and outpatient. Okay, let's say the patient have no other needs to stay in the hospital, the doctor will going to discharge them. Okay, but later on, patient need to come back for their rehabilitation appointment as a outpatient.
mm.
Okay.
Yeah. Yeah, and of course it's time and energy consuming compared to home service, right?
Yeah.
Ya, oke. Di rumah sakit juga ada biasanya program rehabilitasi karena ada pusat rehabilitasinya. Eh, jadi untuk pasien yang rawat inap dan juga rawat jalan, tapi pasti akan memakan waktu dan makan energi yang banyak ya. Gitu mengingat pasien stroke itu mobilitasnya terbatas. Okay, thank you for Dinda for the questions. Is there any, yeah, thank you Dinda. Is there any questions from the audience? Okay, or maybe from the lecturers? Okay, yeah. While we are waiting for the questions, I have a question. In Indonesia, there is a trend of telemedicine. So one of the biggest telemedicine in Indonesia called Halodoc. So we can do a consultation with doctor or psychologist in any specialization. For the home care of for nursing home care itself, we already have several telemedicine based application based and website based for the like for the home care, especially for stroke patients. How about in Malaysia?
Okay. Actually, in Malaysia, we also have a telemedicine, which is you can consult by the doctor through online base. Okay, we have wait, yeah. We have tell the doctor care. Okay, online they're very and then we also have a telecare. Okay, so we can also access the doctor. Okay, and ask about the sign and symptom and the diagnosis. But of course, we for the certain cases, especially the serious cases, you still have to go to the hospital or nearest clinic. For the online one is
Okay.
also just for consultation.
Okay. And then maybe the second one, do you have any advices for nursing students? What kind of maybe knowledge or skills that they have to prepare for caring the stroke patients? The special skills and special knowledge they have to prepare.
For today we have bachelor in nursing and also diploma in nursing, isn't it?
Yeah, true.
Okay, right. Actually, me myself also don't have any encouragement to join a nursing at first. Okay, But when I'm joining nursing, okay, after some time, after I'm graduate, that I think that nursing is the best ever, career, which is you can touch somebody's life. Okay, so that's mean if you want to be a nurse, if you are choosing to be a nurse, so please be a good nurse, which is you will affect them directly or indirectly. Okay, so to be a good nurse, you have to prepare yourself mentally, emotionally, because you will face all kind of emotional, of kind of people. You will interact with multicultural, multi-language, okay, multiracial, yeah. And then, as I mentioned before, we are touching somebody's life. So make sure you be remembered as a good one. Okay. So in terms of academic, I think there is I will not touch about the academic, but nowadays I see that most of the staff nurses less of empathy. Okay. So maybe we can emphasize on that. Okay. More on empathy, sympathy. Okay. And of course, to be sustained in our nursing profession, the communication is the essential thing. Okay, that's all.
Ya. Oke, tadi saya bertanya kira-kira pengetahuan spesial apa atau kemampuan spesial apa yang harus seorang mahasiswa keperawatan untuk menghadapi pasien stroke. Kemudian Madam Sri menjawab bahwa ada dua yang terpenting, yaitu empati dan komunikasi, karena beliau melihat sekarang itu banyak orang kekurangan empati. Padahal menjadi perawat itu adalah karir yang sangat berharga karena bisa menyentuh langsung hidup orang, baik secara langsung maupun tidak langsung gitu. Karena kita berhadapan langsung dengan hidup orang, maka jadilah perawat yang baik gitu ya. Oke. Okay. Are there any questions? You can raise your hand in Zoom. Madam Sri, could you take off your presentation, maybe?
Okay.
Okay. Okay. Okay, I'm in the mute mode. Okay, so I think we already uh, in at the end of our session. Thank you so much, Madam Sri Wahyuni, for your valuable time and your valuable knowledge that already shared with us. I hope all of the audience, especially nursing students, gain many insights, especially in the case of home care service in stroke patients. Once again, thank you so much.
Thank you.
Okay.
Have
Yeah,
a good
before
day.
yeah, thank you so much. Okay. Then I will, yeah, I will give the time and the place to MC Taskia. The place is yours.
Okay, thank you very much, Madam Sri Wahyuni and Mr. Wimba for guiding the last session. It's very insightful session. And now we would like to express our gratitude to our honorable speaker and moderator by presenting with certificate of appreciation. And for the operator, please show the certificate. Okay, first we present the certificate for our first honored speaker, Madam Rahimah and Muhammad, and our second honored speaker, Madam Sri Wahyuni Azhar. Thank you, Madam, for the presentation that is so informative, inspiring, and full of insight. And the second, we present the certificate to our beloved moderator, Mrs. Rofana and Mr. Wimba. Thank you for your role and dedication in guiding the presentation session very well. Okay, and congratulations to our honorable speaker and moderator. Ladies and gentlemen, we have reached the end of today's event. On behalf of the organizing committee, I would like to thank our honorable speaker, our moderator, and most importantly, all of you for your active participation and the attention to regard this event. And we hope this session has been both insightful and inspiring. Let us carry the knowledge we have gained today into our professional and personal lives. We look forward to seeing you at our next event. With that, I officially close the International Expert Lecture 2024. Thank you, everyone, and stay healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, thank you, everyone.
Thank you, everyone.
Aku sudah mulai lupa, tak pernah merasakan marah oleh harapan yang pupus hingga hati cedera serius. Terima kasih kalian, barisan para mantan dan semua yang pergi tanpa sempat aku miliki. Tak satu pun yang aku sesali, hanya membuatku semakin terlatih. Oh! Begini rasanya, terlatih patah hati, hadapi gedihnya, terlatih disakiti, bertepuk sebelah tangan, sudah biasa, ditinggal tanpa alasan, sudah biasa, luka itu pasti, tapi aku tetap bernyanyi. Lama tak ku dengar tentangnya, yang paling dalam tancapkan luka. Satu hal yang aku tahu, terkadang dia juga rindu. Terima kasih kalian, barisan para mantan dan semua yang pergi tanpa sempat aku miliki. Tak satu pun yang aku sesali, hanya membuatku semakin terlatih. Oh! Begini rasanya, terlatih patah hati, hadapi gedihnya, terlatih disakiti, bertepuk sebelah tangan, sudah biasa, ditinggal tanpa alasan, Ingatlah dikala engkau sanggup melihat matahari, hangatnya masih terbawa untuk melangkah hari ini. Hapuskan segala keraguanmu, masa lalu takkan melemahkanmu. Lupakan gelisahmu, teruslah kau mencari. Waktu akan selalu mengobati. Temukan semua yang terhenti dalam hidupmu. Tak perlu kau sesali, hidup kan membuatmu memahami. Coba untuk tetap berdiri, jalani mimpi. Ingatlah dikala engkau ringan terbawa kata hati, melangkah di jalan terang, selalu sadari yang kau miliki. Hapuskan segala keraguanmu, masa lalu takkan melemahkanmu. Lupakan gelisahmu, teruslah kau mencari. Waktu akan selalu mengobati. Temukan semua yang terhenti dalam hidupmu. Tak perlu kau sesali, hidup kan membuatmu memahami. Coba untuk tetap berdiri, jalani mimpi. Teruslah kau mencari. Waktu akan selalu mengobati. Temukan semua yang terhenti dalam hidupmu. Tak perlu kau sesali, hidup kan membuatmu memahami. Coba untuk tetap berdiri, jalani mimpi. Aku mengerti perjalanan hidup yang kini kau lalui. Ku berharap meski berat kau tak merasa sendiri. Kau telah berjuang menaklukkan hari-harimu yang tak mudah. Biar ku menemanimu, membasuh lelahmu. Izinkan ku lukis senja, mengukir namamu di sana. Mendengar kamu bercerita, menangis tertawa. Biar ku lukis malam, bawa kamu bintang-bintang, untuk temanimu yang terluka. senja, mengukir namamu di sana, mendengar kamu bercerita, menangis tertawa. Biar ku lukis malam, bawa kamu bintang-bintang, untuk temanimu yang terluka, hingga kau bahagia. Untuk temanimu yang terluka, hingga kau bahagia.
Ku terima suratmu, aku baca dan aku mengerti betapa merindunya